Welcome back to the deep dive. You've brought quite a specific one today, Pyoderma gangrenosum.
That's right. It's definitely specific and, well, pretty important for exams like the MSRA. Lots of key features to know.
Exactly. So our mission today, take all this info you've gathered on Pyoderma gangrenosum, PG, and boil it down. High-yield facts only, like a quick revision blast.
Perfect. Let's focus on the essentials, the clinical pearls you absolutely need to recall. Make it stick.
Great. Let's jump right in. At its heart, what is Pyoderma gangrenosum?
Okay, so the definition. It's a rare skin disorder, it's inflammatory, and crucially, it's non-infectious in origin.
Inflammatory, non-infectious, got it. But what does it actually look like?
That's the key. It causes these ulcers on the skin, and they're typically very painful, and they progress really, really quickly.
Painful and fast. Okay. And there's something specific about the edges, right?
Yes, absolutely vital. The borders are often described as undermined. Think of it like the edge isn't flat with the skin, it's sort of raised, and it curls or hangs over the base of the ulcer.
Ah, like a little lip or ledge around it.
Exactly like a ledge. That visual clue, that undermined border, is really characteristic. You see that, you should think PG.
Undermined borders. Okay, I can picture that. And you stressed non-infectious. Does that mean infection is never involved?
Well, not quite. The cause isn't an infection, it's driven by inflammation. But like any open wound, these ulcers can definitely get secondarily infected with bacteria later on.
Right.
So ruling out a primary infection causing the ulcer is always step one. But yeah, PG itself isn't started by bugs.
Makes sense. Rule out infection first. The notes also mentioned it's sometimes linked to other illnesses or just appears on its own.
Yeah, that's a really important split. Around 50% of the time, we actually can't find an underlying cause. That's idiopathic PG. But in the other half, it's associated with various systemic diseases, and that's a huge clue for diagnosis.
Okay, let's unpack the why, the etiology. What actually triggers this inflammation?
Well, the honest answer is the exact cause is still a bit murky. We know it involves the immune system going wrong, an abnormal response. But the precise how isn't fully understood. What we do have is a list of things that seem to trigger it or are associated with it.
Okay, like what kind of things?
Things that can stir up the immune system, basically. Trauma to the skin is a big one. Surgery, certain medications. There might even be genetic factors or environmental triggers involved.
Trauma.
Yeah.
Is that related to this Pathergy thing I read about?
Spot on. Yes, Pathergy. It's a really fascinating and clinically important feature seen in maybe 20–30% of PG cases.
So what is it exactly?
It's where minor injury or irritation to the skin actually causes a new PG lesion to appear or makes an existing one much worse.
Wow. So like getting a simple injection or a biopsy, even an insect bite could potentially kick off a PG ulcer.
Precisely. It's this exaggerated, sort of out-of-control inflammatory reaction to what should be a trivial injury. The sources mention things like skin tests, needle sticks, surgical sites, all potential triggers.
That's crucial to know, especially thinking about investigations. You wouldn't want a biopsy if you suspected PG without thinking about Pathergy.
Exactly. It has big implications for management, too. You mentioned medications as triggers earlier.
Yeah, were there specific ones?
Yes, the material listed a few. Propylfurosol, pegfilgrastim, isotretinoin, and cafitinib. Not common triggers, but worth knowing they're linked.
Okay. And going back to the associated diseases, the non-idiopathic cases, what are the main ones we need to have on our radar?
This is definitely high yield for exams. Top of the list is inflammatory bowel disease, IBD.
Right. Crohn's and ulcerative colitis.
Exactly. Particularly UC and Crohn's.
Right.
About 10–15% of PG cases are linked to IBD. Then there's arthritis of various types, but especially rheumatoid arthritis.
Okay.
Also things like lupus, SLE, and certain blood disorders are quite strongly associated myeloproliferative and lymphoproliferative disorders.
So bottom line, if you see a nasty, painful, undermined ulcer in someone with, say, Crohn's or RA, PG needs to be right up there in your thoughts.
Absolutely. It's a massive red flag. The underlying condition is key.
Which leads us nicely to risk factors. Apart from having these diseases, who's more likely to get PG?
Technically, it can hit anyone, any age, gender, but it does tend to be more common in adults, particularly peaking over 50 years old. And there's maybe a slight tendency towards women.
But the big risk factor is really having one of those conditions.
Yes, that's the strongest link. Having IBD, RA, a hematological malignancy, That significantly increases the risk. Plus, maybe some genetic predisposition or a history of other autoimmune issues. It all points back to that theme of immune system dysregulation.
Right, the immune system is definitely center stage. So let's get into the pathophysiology a bit more. What's actually happening in the skin to cause these ulcers?
Okay, so we know it's this exaggerated immune response. The key players seem to be neutrophils.
Neutrophils, those are the common white blood cells, the sort of first responder.
That's them. In PG, something goes wrong with how they function. They become hyperactive or dysregulated. They rush into the skin in huge numbers, but instead of just dealing with the problem, their activity actually causes massive tissue damage, leading to the ulcer forming.
So it's almost like friendly fire, the body's own defenders causing the damage.
That's a good way to put it, like the firefighters arriving and causing more destruction than the fire itself. The precise triggers for this neutrophil chaos aren't fully nailed down, though. It's still an active area of research.
Okay, conceptually that makes sense, even if the fine print is missing. Now, ulcers. Lots of things cause ulcers. This must be a huge area for differential diagnoses. What else could it be?
Absolutely critical section, this, because PG is often diagnosed by excluding other things. You have to think broadly.
So what's top of the list to rule out?
Vascular causes are common ulcer culprits, so venous ulcers, especially on the legs, and arterial ulcers. Also, cutaneous vasculitis can present with ulcers.
And infection obviously has to be ruled out.
Definitely. Probably the most important thing to exclude urgently. Bacterial infections are common, but you also need to think about necrotizing fasciitis if it's progressing incredibly rapidly.
Right, that's an emergency.
Absolutely. And don't forget fungal infections, viral causes, even parasites in some contexts.
Okay, vascular infection. What else?
Malignancy. Some skin cancers like squamous cell carcinoma or cutaneous lymphoma can ulcerate. Sometimes even insect or spider bites can cause nasty-looking lesions initially. You also have to consider, in some cases, self-inflicted wounds. And another inflammatory condition called Sweet syndrome, which also involves neutrophils, can sometimes look similar.
That's quite a list. Okay, let's try a quick scenario, exam style. Say you have a 45-year-old with known ulcerative colitis. They come in with a really painful ulcer on their ankle that's grown rapidly over 2 days. The edge looks purplish and kind of rolled under. What are you thinking, and what do you need to rule out urgently?
Okay, painful, rapid, rolled purple edge, history of UC, screams PG. Right?
Yeah, it sounds classic.
But you can't just jump to that. The rapid progression and severe pain mean you must rule out necrotizing fasciitis immediately. That's life and limb threatening.
Okay, top priority.
Then you rule out the more common things like venous or arterial insufficiency, especially if they have risk factors. You need swabs for infection, maybe imaging. Even consider malignancy, though less likely with that speed. The UC history makes PG highly likely, but rule out the emergencies first.
Great point. Don't anchor on PG even if it looks typical. How common is this condition overall, epidemiology-wise?
It's rare. The sources say definitely rare in the UK. Worldwide estimates are maybe 3 to 10 cases per million people per year.
Wow, okay, so really not something you see every day.
Exactly, which means you need to have it in the back of your mind when you see a suspicious ulcer, especially with those associated diseases, because you might not encounter it often.
And just to recap the demographics.
Any age, but more common in adults, peak over 50, slight female lean.
Got it. So let's focus on the visual again. The clinical features, what are we looking for?
Okay, hallmark again. That painful ulcer. Often starting small, maybe as a pustule or a little nodule, then it grows, sometimes dramatically fast, into a deeper ulcer.
And the borders.
Undermined, violaceous, that means purplish, or erythematous, red. The base of the ulcer itself often looks quite angry, described as boggy, maybe necrotic, definitely inflamed.
And where do they usually pop up?
Most commonly on the lower legs, the shins or ankles. But they can occur anywhere on the body. Sometimes patients feel unwell systemically to fever, malaise, particularly if it's severe.
There's a useful tip in the notes. Consider PG in any ulcer that just isn't healing.
Yes, that's a really practical point. If an ulcer isn't responding to standard treatment and you've ruled out the common things, keep PG on your differential list.
Good advice. Now, the notes also mention different types or variants of PG. It's not always that classic leg ulcer.
Correct. There are several clinical patterns, which is important to know. The classical PG is what we've mostly described. Pustular nodule turns into a rapidly enlarging ulcer, raised boggy necrotic base, often on the legs or trunk. Then peristomal PG. This happens around stomocytes, colostomies, ileostomies, very strongly linked with IBD patients.
That makes sense.
Vegetative PG is a bit different. Often a single lesion, looks more like a superficial plaque or shallow ulcer, less aggressive. Tends to occur in healthier people, maybe on the head or neck.
Right.
Bullous PG, this one starts with painful blisters bullae.
Hmm.
They then break down to form more superficial ulcers, often on the face or upper limbs. This variant is particularly associated with blood disorders.
Blisters first, then ulcers. Okay.
Pustular PG presents mainly as multiple sterile pustules, often with fever and joint pain. Can be linked to IBD flares.
Hmm.
There's also genital PG, typical ulcers just located on the genitalia, and rarely extracutaneous neutrophilic disease where the inflammation affects internal organs, lungs, bones, eyes, etc. Symptoms depend on where it hits.
Wow, quite a spectrum. You mentioned a memory tip earlier for the classic look, PU.
Yeah, just a simple way to remember the key features of classical PG. Painful ulcer with boggy undermined borders, PUB.
PBU. Nice and simple. Okay, let's try another quick scenario on variants. A 60-year-old man with known myelodysplastic syndrome. A blood disorder develops sudden painful blisters on his face and arms. Some burst, leaving shallow erosions. No fever. Which variant fits?
Okay, key features. Blisters, flagrant breaking down, face and upper limbs involved, and, critically, the history of a hematological condition, MDS. That pattern strongly points towards bullous PG.
Perfect. Ties it all together. So if we suspect PG clinically, how do we investigate? We touched on this, but let's consolidate.
Right. And the big message from the sources is diagnosis is mainly clinical. It's about recognizing the pattern, considering the associations, and then systematically excluding everything else.
So the tests aren't really to confirm PG, but to rule out the mimics?
Exactly. That's the crucial mindset. A skin biopsy is usually done, yes, but its main job is to rule out cancer, vasculitis, infection.
Not to diagnose PG itself.
Well, the histology in PG shows lots of neutrophils and tissue damage, but it's generally nonspecific. There's no single microscopic feature that screams, this is definitely PG. So biopsy helps exclude other things, but it doesn't typically prove PG.
That's a really important distinction for exams. Biopsy to exclude, not confirm. What about bloods?
Standard stuff initially. Full blood count, check inflammatory markers like ESR and CRP, usually high. Liver function, kidney function, check urine for protein. And if you suspect an underlying autoimmune condition, you do the relevant rheumatology screens.
What about autoantibodies like ANCA?
They can be relevant. PANCA is sometimes positive, especially in PG linked to IBD. CANCA might be positive too, but if you see that, you need to think carefully about granulomatosis with polyangiitis or GPA, which is a type of vasculitis.
Okay, so CANCA might point away from PG towards something else like GPA.
Potentially, yes. It needs careful interpretation and context.
Any other investigations?
If IBD is suspected, an endoscopy might be needed. And I'll say it again, swabs and tissue cultures from the ulcer base are absolutely essential. You must rule out infection.
Mandatory swabs and cultures. Got it. Okay, quick question based on that. Which investigation is generally least specific for actually confirming PG, even though it's important for other reasons?
That would be the histology from the biopsy. Useful, necessary even, but usually not diagnostic of PG itself.
Perfect. Diagnosis equals clinical picture plus exclusion. So once we're reasonably sure it is PG, how do we treat it?
Treatment really needs a team approach dermatology, maybe rheumatology or gastroenterology depending on the cause, plus specialist wound care nurses. The aims are straightforward: get the inflammation down, help the ulcer heal, and treat any underlying disease.
And the main tools are?
Broadly, immunosuppression and good wound care. How much immunosuppression depends on severity.
So for milder cases?
For localized or less aggressive disease, you might start with super potent topical steroids like clobetasol ointment. Sometimes topical tacrolimus is added. Intralesional steroid injections directly into the edge of the ulcer can also work well.
And if it's more severe or widespread?
Then you need systemic treatment. High-dose oral corticosteroids like prednisolone are often the first line. Start high, then slowly taper down as it improves.
Okay, steroids are key. Anything else?
Yes, interestingly, high-dose tetracycline antibiotics like limecycline or doxycycline are sometimes used, possibly for their anti-inflammatory effects rather than antibacterial. Other options for tougher cases include colchicine, cyclosporin, or sulfasalazine, especially if linked to IBD. And increasingly, biologic agents like infliximab, a TNF-alpha inhibitor, are used particularly for IBD-associated or refractory PG.
Right, so a ladder of options depending on severity and underlying cause. And wound care runs alongside all this.
Absolutely crucial. The right dressings are needed to manage exudate, protect the surrounding skin, and create a good environment for healing once the inflammation is controlled.
And what about surgery? Like cutting away the dead tissue?
Ah, yes. Very important point. Linking back to Pathergy, generally surgical debridement should be avoided or postponed until the inflammation is well under control with medication.
Because it could trigger pathogy and make it worse.
Exactly. Operating on active PG can cause the ulcer to spread or new lesions to form. Once the inflammation is suppressed, then surgery like skin grafting might be considered for very large, stable defects.
It makes total sense. Avoid poking the bear.
Precisely. The sources also mention that high-quality trial evidence for PG treatments is a bit limited, so management often relies on expert consensus and guidelines.
Good to know. What's the outlook generally? The prognosis?
It's pretty variable, honestly. It really depends on the underlying cause, if there is one, how severe it is, how well it responds to treatment, and the patient's overall health.
Can people get completely better?
Yes, with the right treatment, many ulcers can heal, although often leaving significant scars. But recurrence is definitely a risk. Some people struggle with chronic, non-healing ulcers for a long time.
What influences the outcome?
Factors like the type of underlying disease, if any, age, maybe gender, and especially if it's associated with a malignancy that tends to carry a worse prognosis. Some studies suggest overall mortality might be higher than the general population, but that's often tied to the severity of the associated systemic conditions.
So managing the underlying IBD or RA or whatever it is critical for the PG prognosis too.
Absolutely. It's all linked.
What are the main complications we worry about with PG itself?
Well, the ulcer itself causes significant pain and can really impact quality of life. Complications include those chronic non-healing wounds we mentioned. Scarring is almost inevitable after healing. Secondary bacterial infection is a big problem, makes healing harder, increases pain and inflammation. Then there are complications related to the underlying diseases. And those rarer things like the extracutaneous disease or eye problems. Don't forget things like wound odor and general debility from large painful ulcers too.
Yeah, the impact on day-to-day life sounds huge. Pain, scarring, infection risk.
Definitely. It can be a really debilitating condition for patients.
Okay, let's pull it all together. Thinking about someone revising for MSRA, what's the absolute core message, the final thought on Pyoderma gangrenosum?
I'd say recognize the pattern. Painful, rapidly expanding ulcer. Those undermined violaceous borders see that, especially with a history of IBD, arthritis, or blood disorder. And PG must be high on your list. Remember, it's inflammatory, not infectious initially. Remember, Pathergy minor trauma makes it worse. Diagnosis is clinical plus exclusion. Biopsy rules out other things. Management is immunosuppression, steroids first line often, and careful wound care, and crucially, delay surgery on active lesions. It's rare, but missing it leads to delays and potentially poor outcomes. Nail those core concepts.
That's a fantastic summary. Pattern recognition, exclusion, pathergy, immunosuppression, hold the knives. Really clear, high-yield points from all that material. This has been a really insightful deep dive.
Glad we could distill it down. Hopefully that helps make it stick for revision.
I'm sure it will. Thanks so much for walking us through this complex topic. And for everyone listening, for more free MSRA revision resources, you can visit freemsra.com. For the full premium revision toolkit, head over to passmsra.com. Thanks for joining us on the deep dive, and we'll catch you on the next one.